Good day. Today I will be presenting the algorithm for blood pressure management in patients presenting with acute stroke in the emergency room. Step 1. Identify the type of stroke. When a patient presents with acute stroke, the first step is to determine whether it is hemorrhagic stroke or ischemic stroke. Management differs depending on the type. Red, hemorrhagic stroke. Step 2. Check systolic blood pressure. If SBP is less than 180 millimeters per mercury, maintain blood pressure stability. Avoid fluctuations or variability. If SBP is greater than 180 millimeters per mercury, carefully lower BP to 140 to 160 millimeters per mercury. Avoid rapid drops. Specifically, avoid reducing SBP by greater than 60 millimeters per mercury within 1 hour, as this may worsen cerebral perfusion. The goal in hemorrhagic stroke is controlled BP reduction without compromising brain perfusion. Blue, ischemic stroke. Next, determine if the patient is a candidate for IV thrombolysis or thrombectomy. 1. If candidate for thrombolysis or thrombectomy, check BP. If BP is greater than 185 over 110 millimeters per mercury, lower BP to below 185 over 110 millimeters per mercury before treatment. Maintain BP below 185 over 110 millimeters per mercury during infusion. After treatment, for the next 24 hours, maintain BP below 180 over 105 millimeters per mercury. If BP is already below 185 over 110 millimeters per mercury, proceed with therapy. Maintain BP below 180 over 105 millimeters per mercury for 24 hours post-treatment. 2. If not a candidate for thrombolysis, check BP. If SBP is greater than 220 millimeters per mercury or DBP is greater than 120 millimeters per mercury, initiate BP lowering. Gradually reduce BP. If SBP less than 220 and DBP less than 120 millimeters per mercury, do not aggressively lower BP. Maintain mean arterial pressure, MAP, between 110 and 130 millimeters per mercury. However, initiate BP lowering if there are serious comorbid conditions such as acute coronary syndrome, acute heart failure, aortic dissection, post-fibrinolysis state, symptomatic intracerebral hemorrhage, preeclampsia or eclampsia. Medications for BP lowering. If BP reduction is needed, nicardipine IV. Start at 5 milligrams per hour, increase by 2.5 milligrams per hour every 5 to 15 minutes, maximum dose 15 milligrams per hour. Or labetalol IV, 10 milligrams IV over 1 to 2 minutes, followed by continuous infusion of 2 to 8 milligrams per minute. Summary. In summary, determine stroke type. In hemorrhagic stroke, controlled BP lowering. In ischemic stroke, decide if the patient is a thrombolysis candidate. Follow strict BP thresholds before and after treatment. Avoid rapid BP reductions to preserve cerebral perfusion. This algorithm ensures optimal cerebral perfusion while minimizing complications in acute stroke patients. Thank you.